Hey, everybody. It's Miss Mary here. So this lecture is going to be on nursing management and leadership. So let's get started. Let me share my screen and I'm going to tell you what you need to know. Okay? Because you need to know some stuff. Very important. And here we go. Okay. And here we are. Okay. So what are we going to learn? We're going to identify the factors that influence changes in the healthcare delivery system, describe safe health practices, explain how significant hospital acquired conditions or infections are. We're going to go through the leadership styles, discuss what the role is for the LPN in leadership and delegation. We're going to describe the importance of ethics in healthcare, what moral distress is or moral fatigue, and what kind of effect it has on nursing care, the steps in the ethical decision-making model, identify who and where the regulation of nursing practice is defined, explain what is mandatory for reporting for healthcare professionals, like what you have to report to the Board of Nursing or to the Department of Health. We're going to talk briefly about human trafficking that needs to be reported. We're going to talk about HIPAA, guidelines for social media, how to provide quality care and limit your liability, organ and tissue donation and recovery in New Jersey. And we're going to look at our Nurse Practice Act for New Jersey. Those are the regulations that govern us. And then finally, we're going to review the National Patient Safety Goals from JACO, which is the Joint Commission on Accreditation for Healthcare Organizations. Okay, everybody's probably heard of JACO. Okay, let's get started. Healthcare delivery. So when we talk about continuity of care, we're talking about the health and illness continuum. What does that mean? It means that there's got to be a connection. Can't be working in silos or broken up. Got to be a connection between the patient or the client when they're healthy. And then if they do wind up in the healthcare system and all the people involved in their care, whether they're related in the same organization or not, have to be able to communicate with each other so that there's no compromise in the care of the patient. Okay, I hope that makes sense. So when we look at an integrated care delivery network, we look at, the hospitals kind of at the core. Then we've got home care, right? Home health services, rehab, one-day surgery, ambulatory surgery, diagnostic centers like MRI, CT scan, hospice, consumer education, extended care, long-term care, subacute, long-term care, ambulance services. And then, of course, what should be going hand in hand with this is the primary care physician, right? And that's the doctor that manages the care all the way around. So what are the factors that are influencing this healthcare change? The healthcare as we know it in this country is a little bit broken, in case you haven't noticed. So, and there are lots of contributing factors to it. The increasing population. There are a lot of people in this country. The increasing number of older adults. We are keeping people alive longer. 50, 60 years ago, people were dead by the time they were my age. Right? Okay. Now people are living to be in their 80s, their 90s, 100s, right? And we have an increased cultural diversity in this country. So more and more people from different ethnicities. And that brings us to genetics in the human genome, which plays a significant role in healthcare and wellness and illness. Evidence-based practice. You're going to hear me say this a million times. Everything that we do needs to be based in evidence-based practice. Research with empirical, provable data that says, hey, this is the right way to do this for the patient based on everybody in the healthcare community consensually agreeing to that, but based on experience, right? And we'll talk more about that. MDROs, multi-drug resistant infection organism, MRSA, methicillin-resistant Staph aureus, VRE, vancomycin resistant enterococcus. Those are things that you used to only get in a hospital or a facility of some type. Now there's community acquired MRSA and community acquired VRE. So that's having an impact on the healthcare system. emerging viruses, COVID, right? We're not going to get too in depth about human trafficking. We'll touch on it briefly. EMRs, electronic health records, right? That's having a big impact on the care delivery. And mobile health, having tablets and smartphones, digital apps, telehealth, remote patient monitoring, robotics for surgery. Nursing informatics is the venue of nursing that focuses in on the technology, which I love, in case you haven't noticed. So what kind of an impact can these things have? So let's talk about some things that happen too frequently, sadly, medication errors. So medication errors can really be diminished with the use of technology. They can be increased with things like distractions or fatigue. If you work a double shift in a nursing home, if you work a 16-hour shift, after the first 8 hours, your chances of having a mistake, whether it's a medication error or a treatment error or any kind of error, increase exponentially with every hour over 8 that you work. So it's a problem. And then, we have to make sure that we understand the interventions to prevent med errors. Somebody's pouring meds, don't interrupt them, right? And try to avoid anybody interrupting you if it's possible. But, the one thing I tell people, I worked in the ER. There were alarms ringing and bells ringing and phones ringing and people were screaming and other people were yelling and a lot of chaos. You have to kind of learn to be in your own bubble when you are working with medications because you don't want to make an error. It could be deadly. And then the Joint Commission's National Patient Safety Goals. There are goals for every venue of nursing, long-term care, subacute, the hospital. There's also a set of goals for hospice care and home care. For our intents and purposes, we're going to talk about just long-term care, subacute, and the hospital. And what they did was the Joint Commission got together with the Centers for Medicare and Medicaid Services, CMS, and came up with this National Quality Forum to decide what are reportable events and how can we make everything, including the health information technology, safer for both ourselves and for our clients. So let's take a look at these safety goals. I took a screenshot of the hospital safety goals. I'm going to make this bigger. So the goals are, identify your patient correctly. You always use 2 ways to identify your patient. Example, name and date of birth. Okay, you need both of them. You can't just have the name or the date of birth, both. Okay, patient's phone number. Yeah, phone number is an identifier that you could use also. You have to make sure that you're giving the right drug to the right patient, right? And that you're providing the right care to the right patient. There have been historically many events with wrong patients, patients receiving someone else's meds. Think about if you gave someone who's not diabetic a dose of insulin, you could kill them. Improve staff communication. So in other words, getting communication to the right staff person on time. If your patient went and had a test, you want the results of that test as quickly as possible, right? Safe medication use. Make sure that medications are all labeled, right? Never pre-pour meds. Let me say that again. Never pre-pour meds, okay? When you are ready to give them is when you pour them. And never administer medications that another nurse poured. Nurse comes up to you and says, oh my God, I'm in a rush. Here, do me a favor. I already poured these meds for Mrs. Jones. We just give them to her? Nope. Don't do it, okay? You don't know what's in there. Extra care with patients who take anticoagulants, okay? Blood thinners, anticoagulants. And make sure that you're documenting and passing along the correct information about patients' meds. When you're talking to a patient, like during an admission, what meds are you taking? Everything. Ever take Tylenol? Ever take Advil? Do you take any vitamins or supplements? You need to know every single thing, okay? And we need an up-to-date list because herbals, just because they're herbal, doesn't mean they're safe, right? Okay. Alarms. There's something called alarm fatigue. So if you're working on a unit where, there are alarms that are constantly going off, after a while, you just don't hear them. That's a problem because the time that you don't hear them is the time that you really need to hear them. So preventing infection, hand washing, the simplest thing, hand washing. Hand washing, when done correctly, can really prevent so many infections. If your hands are visibly soiled, you must wash them. You wash them before you touch a patient. You wash them before you put gloves on. We wash them after you take gloves off. Wash your hands. Hand sanitizer, right? Also, identify patient safety risks. Is this patient a risk for suicide? Do they have suicidal ideation with a plan? So thinking about suicide is one thing, but thinking about it and saying, I know I have a bottle of morphine that I have stashed, I'm going to drink it. That's a plan. And that person cannot be left alone, right? That we need to get somebody for help. Improving healthcare equity. Okay. Equity and equality are not the same. All right. Equality means everyone gets treated the same way. Healthcare equity means that if you suffer from a disparity, such as low socioeconomics, like you're poor or, things like that, you're not well educated. We need to make sure that we're stepping up our game and providing a higher level of care to make sure that those patients or those people that have those disparities or that are lacking in those certain things can get the care that they need. Okay. And preventing mistakes in surgery. That's not for us to do, but I'll just go over them. Make sure that the surgery is being done on the correct patient and the correct body part. Tampa General, a long, long time ago, cut off the wrong leg. Guy wound up a double amputee. That was a problem. We now know that whatever body part is to be operated on needs to be marked with a Sharpie by the patient and by the surgeon. Okay. And there should always be a pause before surgery even starts to make sure that it's correct. Okay. So those are the hospital goals. Now let's look at long-term care. Nursing care center is what they call it. Same kind of goals. Identify patients correctly, right? Name, date of birth, name and phone number, right? 2 identifiers. Be careful with medications that are blood thinners, anticoagulants, warfarin, Coumadin, Januvin, all the same drug. Heparin, enoxaparin, which is Lovenox, clopidogrel, which is Plavix, even aspirin or baby aspirin. They are antiplatelet aggregators and they can thin the blood. So make sure that they have written information about any restrictions they have, and make sure they understand signs and symptoms of potential bleeding that they need to report. Wash your hands, wash your hands. Fall prevention, okay? Make sure that we are addressing it before it happens. So who is most likely to fall and why? Are they taking meds that might make them drowsy or dizzy? Do they just have generalized weakness? Did they have a stroke? Make sure that this is documented and then interventions are put in place to prevent them from falling. And then preventing decubitus ulcers, okay? There's something called a Braden scale, which I will send everyone a copy of that. The Braden scale helps to predict the risk level for someone, the risk for getting a bed sore. So, you're supposed to reposition patients that cannot reposition themselves every 2 hours. If someone has a non-blanchable area of hyperemia, what does that mean? Means when I push on the skin, it's supposed to blanch, turn white, and then get pink. If I push on it and it stays red, that's hyperemia, and that's a stage 1. So most likely to happen at the sacral coccyx area, the heels, bony prominences are where pressure ulcers are likely to develop. So you want to make sure that you are preventing. And also if they have oxygen, pressure ulcers behind the ears from the oxygen tubing, nasal cannula. Okay. Right. Next. Oh, let's put this back. Again, with medication safety, if a med is to be given by mouth as a pill, it can't be given a different route. If a med is a liquid, if a med is meant for an IV or meant for an IM, so you cannot give those meds by a different route than they were intended. So if a person is ordered pills, PO meds, and you determine that they're having difficulty swallowing and they're a risk for aspiration, then maybe you want to get that med changed to a liquid med. If they have a PEG tube, right? Some meds can't be crushed. So you want to get those changed to liquid meds, okay? You just call the doctor and get an alternate route for that drug. There are some economic issues, some understatement, that are impacting the healthcare industry right now. There's something called DRGs, diagnosis-related groups. DRG started in the 90s at the hospitals. And it's when Medicare and the insurance company said, you know what? We're going to create these groupings of criteria that will have us determine how long the patient gets to stay in the hospital and what you get paid to take care of them. So, for example, if a patient has pneumonia, 3 days, Time's up. So it used to be that the physician got to decide how long their patient stayed. That started in the 90s. Medicaid reimbursement and doctors that accept Medicaid. Medicaid reimbursement is a lot lower than standard Medicare or insurance reimbursement. And so there aren't a lot of doctors that will accept it, which is not good because people need health care, right? Hospital acquired conditions present on admission. It's important that if you're admitting a patient and they already have a decubitus ulcer, it needs to be well documented. So this way it doesn't look like they developed it while they were staying at your facility. And then managed care, HMOs. I could talk about them all day long, but I won't. So, managed care, HMO, or a form of insurance where you basically need a referral and approval, authorization for everything. From seeing doctors, what doctors you see, what kind of meds you're able to take. Not a fan. Not a fan. Okay. Let's talk about hospital-acquired conditions. So the most likely things that happen to patients when they're in the hospital. Foreign object retained after surgery. Well, we can't do anything about that as nurses. That's on the surgeons. But it's also on the circulating nurse to kind of be there, and the scrub nurse to be watching, and say, hey, we had 6 sponges. We only have 5. Where's the other sponge? Air embolisms. And that can happen because of air in an IV line, right? And that can become a pulmonary embolus, which can mean instant death. Blood incompatibility. Everyone's got a blood type. Before people get blood, we do a cross and type on them. Tells us whether they're A, B, AB, or O. There's 4 blood types, and tells us if they do or do not have the Rh factor, right? So is their blood negative or positive? And we'll talk more about that in a different time. But if somebody's given the wrong blood, you can kill them. Stage 3 and stage 4 pressure ulcers. These are horrible. Stage 3 are painful. Stage 4 aren't really painful because now the wound has gone below the level of the dermis and the tissue. So it's down to the muscle and the bone. It's a deep wound. So the nerve endings aren't really there anymore, but boy, they're hard to heal. So if they already have a stage 1 when they come in, and now it's a stage 3 or 4. Why did we do that? Right? Falls and traumatic injuries. Many of these elderly are fall risks. If we identify them as a fall risk, there are lots of interventions that we can implement to help to try to prevent them from actually falling and getting hurt. And that includes things like using machinery, like the Hoyer lift or the sit-to-stand lift, the right way. I've seen aides use a sit-to-stand lift to change adult briefs. You can't put somebody on that sit-to-stand unless they're awake, alert, and oriented ×3. And they have upper body strength sufficient to hold on. I saw someone fall off of it and break their femur. And let me tell you, they died. So, other things that can happen. Poor glycemic control. In other words, blood sugars all over the place, right? You walk into the hospital and mom's a diabetic and she's got a piece of cheesecake in front of her, right? Pouties, which are catheter-associated urinary tract infections. We don't put an indwelling catheter in someone unless we absolutely must. And, having a wound is not a reason to put in an indwelling catheter unless it's a stage 3 or 4 and it's non-healing. And incontinence is not a reason for a catheter. Okay. Surgical site infection after a CABG, coronary artery bypass graft, which is mediastinitis. The mediastinum, right here in the middle of the chest, they wire it after they do open heart surgery, and infection there. Surgical site infection after bariatric surgery for obesity. Surgical site infection after certain orthopedic procedures, after a cardiac implantable electronic device, which would be like a pacer or AICD. Developing a DVT or pulmonary embolism after a knee or hip replacement. Don't worry about iatrogenic pneumothorax with venous catheterization. That's not something you're probably going to see. So who is part of that interdisciplinary team we keep talking about? LPNs, RNs, nurse practitioners, nurse specialists and midwives, nurse anesthetists, they do anesthesiology, CNAs, certified nursing assistants, doctors of nursing practice. In the state of New Jersey, if you have a doctorate, a DNP, Doctor of Nursing Practice, and you are a nurse practitioner, you cannot have people call you doctor because patients will mistakenly assume that you are a medical doctor or a doctor of osteopathy, an MD or a DO. You are not, right? You have to make sure that that's clear. We've got physicians, PAs, physician's assistants, pharmacists, social workers, dietitians, physical therapists who handle things like walking, ambulation, transfers, those kinds of things. That's what they're for. And then they're physical therapy assistants. And occupational therapists, they have to do with activities of daily living, more like, feeding yourself and washing your hair and bathing and those types of things. Speech and language pathologists, swallow evals are done by them. And also speech therapy, say for someone who's had a traumatic brain injury, a TBI or stroke, right? Respiratory therapists and respiratory therapy technicians. And then you've got your health unit coordinators or secretaries and student nurses. I used to love it when student nurses would come into the hospital where I worked. Loved it. So what do you do as the LPN? You are providing direct patient care, but under the direct supervision of an RN, a healthcare provider, and believe it or not, could be a dentist. Probably not for most of us. Let's talk about leadership now. What does it mean to be a leader? So you have to be able to make decisions. You have to be a good communicator. You have to be inspirational, motivational, right? You have to be kind of like, come on, team, like the cheerleader, let's go, in order to guide them, your team, to be able to do the things that need to be done, right? So there's a cute little picture. There are different types of leadership styles. There are more than 4, okay? Transformational is my favorite. I'm actually going to add that here because it's nice to know. So I consider myself to be a transformational leader. And that means that I'm the one that likes, come on, embrace change. Come on, bob and weave. Let's go, guys. You've got autocratic. I don't like them. They're the ones that say it's my way or the highway. Authoritarian. Democratic, which means I'm not making a decision unless everybody on the unit agrees, right? Participative. Laissez-faire. Just think of lazy. I hate to say that, but that's a way to remember what laissez-faire is. That's a French word, which means whatever you want to do. So that's the leader that just says, whatever you guys want to do, you guys handle it, right? There's a coaching type leader, which kind of falls in with transformational. It's like, rah, rah, rah. Come on, let's do what we need to do. And what are the functions of management? You have to plan, organize, direct, coordinate, and control to a degree what your team is doing. Delegation and leadership for LPNs. So leader manager for care of assigned patients. So you are the leader of taking care of the patients that have been assigned to you. Then you usually will have CNAs, right, to help you. Our state does allow LPNs and LVNs to delegate, but it all has to be done under the supervision of the RN. And we're going to go over the Nurse Practice Act, which tells us our scope of practice, what we can and can't do. So know your state Nurse Practice Act, skills of delegation, and 5 rights of delegation. We'll talk about delegation right now, okay? Delegating something does not mean that you are no longer responsible for its outcome, okay? You delegate a task to someone who is capable and competent to complete that task, and it's not outside their scope of practice, right? But you're still responsible to ensure that it was in fact done and that it was in fact done correctly and timely. So things that a CNA can't be delegated to do. So think about it. As a nurse, nurses, LPNs and RNs can evaluate and evaluate wounds, evaluate a stoma if somebody has an ostomy. CNAs are not allowed to do that. So because of that, you can't delegate a CNA to change a wound dressing, because when they take off the old dressing, they would have to be able to evaluate the wound, and they can't do that. You can't assign them to change an appliance or wafer on an ostomy. They can empty the bag, but they can't change the appliance because they'd have to evaluate the stoma, and they're not allowed to do that, right? So these are the things that you have to keep in mind. You're the LPN working with an RN. If you have a patient that's going home and needs new education on something, a new diagnosis or medicine, you can't start education as an LPN. You can add on to it and continue it and reinforce it. But the RN needs to start the care plan, and the RN needs to start the education. You can then add to it. Okay. There are lots of things that you can do after you graduate and get your license: pharmacology, long-term care, IV therapy. I mean, if you've been told LPNs can't do wound vacs, LPNs can't do IVs, maybe that particular facility had an issue at some point, and their policy in that facility dictates that. But the Nurse Practice Act for the state of New Jersey does not say LPNs can't do wound vacs, LPNs can't do IVs. You can. All right. And again, we're going to go over the Nurse Practice Act. You can move on to education, get your associates, get bachelor's, get your master's, get your doctorate. I want to get my doctorate, right? Never too old. Never too old. All right, let's talk about ethics and values. Ethics, that's traditions, values, and beliefs related to people and their relationships, right? What we believe is ethical in this country may not be the same as in other countries or other cultures. Bioethics is taking those ethical principles and applying them to human life and illness and wellness. And then ethical questions. What do we do? What do we do? Like, don't tell mom that she has cancer. I can't do that. That's unethical, right? I took a vow of veracity. I have to tell the truth. What are morals? Morals are personal values, right? That your conscience kind of sets for you, right? Sometimes they're based in religion. Sometimes if people aren't religious, they're just based in just the idea of right and wrong and good and bad, right? Choices that we make, do the right thing. What is the right thing, right? Just making sure that you're never hurting anybody, right? That you're always trying to keep the other person's best interest in mind, okay? Values are a little bit different than morals because they're kind of concepts that give meaning to people's individual life. So they can come from societal norms. In other words, most of society believes that suicide is wrong. They can come from religion. They can even stem from family traditions. But for every person, they're different, and they will decide and guide what those people's actions are, right? Sometimes consciously, sometimes subconsciously, believe it or not. You as a nurse, you have a responsibility to practice ethically. Okay. You have the nursing ethical principles that you must abide by according to the Board of Nursing. And this is in every state. And those are autonomy. We talked about a little bit about these, and we're going to go over the ethical principles, but you are responsible to practice ethically. You're obligated to do that. So the Code of Ethics, the National Association of LPNs, the National Associations for Practical Nurse Education and Service, and then practice standards with ethical principles for LPNs and LVNs, same ones as from the American Nurses Association that are used by the New Jersey State Board of Nursing, right? They're all pretty much the same. Ethical principles come from moral theories, and they're there to help society have some order, right? How are we supposed to act? How should we conduct ourselves? And they help us apply consistent approaches when there's a dilemma or moral dilemma about something. How do we manage this? What do we do? Patient wants to be a DNR. Daughter says no, right? That's a moral dilemma. So let's talk about the ethical principles really quickly. Autonomy. The patient gets to participate in their plan of care. They must. They have independence. They had a life. They're a person. They're a human being, right? So their input must be considered when we're developing a plan of care. Beneficence, do good. You see someone on the ground and you stop and you help them. You see a car accident and you stop and you help them, right? You do CPR on someone, a drowning victim. Non-maleficence, do no harm. A little bit different than do good. Can be a non-action, can be, patient asks you to do something that would be harmful and you decline doing it. Fidelity, that means trustworthiness. If you say you're coming back in 15 minutes, come back in 15 minutes. If you can't, don't promise it. Veracity, in vino veritas, and wine there is truth. Tell the truth. And then justice, that's equality. That's equal treatment for all. Rich, poor, doesn't matter. Who you are, movie star, homeless guy. Everybody gets the same treatment, right? Convict, we're not police, we're not judges, we're not juries, okay? That is your patient. You take care of them all the same. And then you have the other two, utilitarianism. I really didn't talk about deontology, but I'll touch on it briefly. Utilitarianism, the end justifies the means. How can I get the best outcome for the most amount of people? That's utilitarianism. Deontology is actions based on duty, like to God. So we separate church and state. So we don't really deal with deontology. Theological perspectives, that's religion, right? So some people are very religious and some people base their actions and conduct on the, traditions and the values and morals that their religions dictate. Jehovah's Witnesses will not accept blood or blood products. But, there are instances where we have to override those things. For example, you're working in the ER. There's a car accident. A 16-year-old kid comes in unconscious. He's lost a lot of blood. He needs a blood transfusion. His parents arrive. They say, oh, no, we're Jehovah's Witnesses, no blood. And the doctor and you and the whole team know that if this kid doesn't get blood, he's going to die. We're going to get a court order and we're going to give him the blood. And we're going to deal with the family afterwards because he is not awake, right? So we don't know if he wants to die because of his family's religion. We don't know. And we can't make an assumption, right? So if they believe it, then if they don't want blood, they don't get blood. But we're saving the kid's life. Hopefully that makes some sense, right? Ethical decision-making steps. When you're in an ethical dilemma, and you'll have questions on the boards, not a lot, but a few about ethical dilemmas. You have to say to yourself, all right, who are the people, who are the stakeholders, who are the main people involved, and what are their values? You have to gather as much information as you can. And then you have to say to yourself, if I do this, what will the consequence be? If I do that, what will the consequence be? Right. And then whatever action you decide on as a group, bioethics committee, you have to say to yourself, what is the ethical foundation for us to do this? A good example would be a woman was in a car accident, 30-something years old. Name was Terry Shibo. This was quite a few years ago. She was married. And as a result of the accident, she was brain dead. And so she was dead at the scene. They brought her back, but she was then on a ventilator, and the ventilator was keeping her alive. Without the ventilator, she would die. It was a brainstem injury. Brainstem injury, that affects your involuntary ability to breathe because you don't have to think about breathing. Your body just does it. Well, she couldn't breathe on her own. So her husband wanted to extubate her and wanted to take her off the mechanical ventilation. And if she died, she died because he knew she wouldn't want to live like this. Her parents were very religious. They put up a fight. If one person argues about a decision about a patient that is unconscious and unable to speak for themselves, we're going to the bioethics committee. This thing got national coverage, this whole situation with Terry Shibo. This was in Florida, and the governor of Florida at the time was Jeb Bush. He got involved, which I kind of had a problem, but that's just my own personal opinion. Does not reflect the opinion of any AHE schools or anybody that I work for. It's my own private opinion. At any rate, long story short, the parents were saying, no, she's still in there. Her brain is still in there because when we go in, we see her twitch or her eye blinks. They're going to be involuntary movements. They've done multiple EEGs, electroencephalograms, and there was no voluntary brain activity going on. Ultimately, she was removed from the ventilator, and she did die. But after lying in a bed for years while these people all argued about what to do. So, the bottom line is it's not in anyone's best interest to lie in a bed like a vegetable. I mean, if they're not aware of what's going on. Again, my personal opinion, okay, just mine. People say, well, religion, I can't let her die. If you believe in God, then I don't understand why you don't just let God handle it. Because right now the machine is intervening. We're intervening. That's not God. At any rate, so that's an ethical decision-making process, right? And that went through bioethics committee after bioethics committee, and it was a mess. It was a mess. So have advanced directives, have a living will that clearly state what you want. God forbid something should happen. Okay. You can't speak for yourself. Legal concepts. Once you graduate, you pass your boards, you are a licensed healthcare professional. Your goal is to protect the public, and you are regulated by the Board of Nursing of the state of New Jersey or whatever state you practice in. And we have a Nurse Practice Act that defines our scope of practice, what we are allowed to do and not allowed to do. And you can have your license sanctioned or, suspended or terminated if you violate the Nurse Practice Act. Okay. Violations would include things like unprofessional conduct, and that's very vague, and we'll talk more about this in another video. Incompetence, which is negligence, right? Or not doing something knowing that you don't know how to do it and then harming someone because of it. Conviction of a crime, again, that's kind of some gray area, depends on the crime. And then, of course, misuse of controlled substances, right? They can suspend you or they can revoke you. New Jersey has something called a RAMP program for drug users. This particular textbook says don't go to work after drinking alcohol the night before because, it's still in your bloodstream. And if you were to get tested, it might not be a zero. You might show up having alcohol in your system. If you are on prescription meds, you make sure you have the prescription, right? Controlled substances. If you can't work, you're taking pain pills, opioids or something like that, or benzos. If it affects your ability to work safely to protect your patients, then you shouldn't be working while you're taking them. We're going to get into how to get your license. Okay. We have to report everything that you have, including juvenile, any arrests, even if the charges were dismissed, and of course, any convictions and then what happened. Okay. And once you're licensed, if God forbid something happens after you get your license, you have to tell the Board of Nursing. Mandatory reporting. Okay. If you suspect abuse or that there's abuse going on, vulnerable populations are considered kids, older adults, the disabled, and the mentally impaired. It is your moral imperative to report it. Okay. You must. And there are lots of types of abuse. There's physical abuse, sexual abuse, verbal abuse, emotional abuse, financial, economic abuse, and then neglect. Right. Let's go back to that for 1 second. So physical abuse would be, hitting someone. I worked in an ER. If somebody comes in and they have bruises or injuries all over their body at different stages of healing, your brain should go, that's very suspicious. If they have grip marks on their arms, right? Think about it. Suspicious. If it's a little toddler and his knees are all scraped up, not suspicious, because what do little kids do when they first start walking? They fall, right? So again, there are ways to identify potential abuse. You want to make sure that you are paying attention, right? Sexual abuse, pretty obvious. Rape, right? Doing anything without consent. Verbal abuse, that could be calling somebody names, cursing at somebody, or even trying to make them feel, you're stupid, you're an idiot. Emotional abuse, I hate you, I don't love you, right? Financial abuse, that happens a lot with the elderly, especially in Florida, where, I'm taking care of my great aunt, and then the great aunt's checking account is slowly getting drained, right? And neglect, not turning a patient because if they're immobile and they develop bed sores, not feeding them, not changing their briefs if they're wet, letting them lie in urine or feces. These are all forms of neglect, right? And even it can be emotional neglect. Like maybe you have an aide that comes in and cares for, but you never go in and say, hey, how you doing? Even if they're nonverbal, you don't know, just what a smile can do for somebody. So that's, that's a form of emotional neglect. Human trafficking, I'm not going to get into great detail, although New Jersey does, ask you to do CEUs on it. There are people out there that will look for vulnerable teenagers, male and female, and they will get them hooked on drugs and they will traffic them as human sex slaves. Yeah, 2024, and it still goes on. So if a patient doesn't have identification, or they're in there with someone who will not allow them to answer the question. So do you have any pain? No, she doesn't have pain. Let the patient answer, please, right? Or someone who's making all decisions for the patient or refuses to leave that patient alone. Suspicious, right? Get your social worker, get your charge nurse. There are some physical and psychological indicators like chronic issues like headaches, back pain, stomach ache, and we can't figure out what's wrong because of stress. Memory loss, depression, anxiety, and then, of course, signs and symptoms of abuse and neglect like bruising, malnutrition, or just submissive behavior, right? Do not say anything in front of the victim or the trafficker. Just get with your team immediately, okay? They'll know what to do. It has to be reported to law enforcement and Homeland Security, and there's a trafficking resource center, okay? And then we're getting to the end. HIPAA, not like a hippo, HIPAA, Health Insurance Portability and Accountability Act of 1996. The government imposes civil and criminal liability for healthcare workers who wrongfully disclose a patient's protected health information. And the penalties can be steep, up to 10 years in prison, millions of dollars, lawsuits, right? It's not anything to laugh about. Never, ever, ever talk about a patient or their business in the hallway, in the break room, or on the elevator, where other people can hear. Don't share your password with anybody. You always have to be professional because there could be really serious consequences. Whatever you do, even if you're doing home care and you're like, oh, let's take a selfie, me and my patient, please don't do that. Okay. We know, you're living a life. You don't need to post things on social media every second. Look at my lunch. Drives me crazy. But, you can't take pictures of patients or their homes or their family or even with their permission, because then that's disclosing, oh, she's a patient in a hospital. Like that's no one's business. Okay. And what we're talking about is things like we talked about photos already, unauthorized access to medical records. You find out that, Cardi B is up on the 5th floor. Oh my God, what's she in for? Let's take a look. Don't do that. You're not providing care for her. You don't have access to her medical records. Okay. You're not supposed to be looking at them. And if you do, I'm telling you, the fines and the penalties are steep. So criminal law, like I said, imprisonment and fines, and civil law, you can get sued. Speaking of suits, healthcare workers can get sued. It happens. We have tort laws. That's lawsuits for personal injury, medical malpractice, right? Civil liability suit. When you're working for an employer, they have liability insurance to cover their employees. So if you're a full-time employee, W-2 employee, if you are an I-9 employee, in other words, if you work and they don't take taxes out of your check, like agency work, you really should have some liability insurance of your own. NSO, Nurses Service Organization, is where I used to get my insurance. They're pretty cheap. Something to think about. Malpractice means that you didn't do what any other prudent nurse of your experience and educational level would have done, right? Negligence, that means that you didn't do something that you should have done and somehow someone got hurt because of it. So if you don't want to have liability, make sure you're following patients' rights, the policies and procedures of your institution, most current evidence-based practice, nursing standards, documenting, so important, right? And oh, by the way, incident reports, and this is important, when you document, let's say that there is a med error or someone fell, that gets documented on an incident report and does not go in the patient's chart. And we will talk more about documentation. So I'll do another video on that. And make sure you do continuing education because things change. Medicine is fluid every second. In the time it took me to make this video, probably 25,000 new things happened. Okay, it's important. I'm not going to go over the questions, but I hope that was helpful for you guys. That is the crux of leadership and management, just so you understand. So you must understand HIPAA, delegation, all the things that we covered today. So hope that was fun. Until next time, see ya. And bye.